This week is possibly one of the most significant in terms of the coronavirus pandemic in South Africa for a lot of reasons. Some industries and businesses are opening this week, which could see about 1.5 million people going back to work. Now, not only will they find themselves in new situations where sanitation is essential, but they are also going to be commuting as well as interacting with other people. In addition, schools, other institutions and government organizations are all making plans to reopen. So in many respects, this is a new beginning for South Africa. Let's check in with South Africa's most senior expert on this topic. And joining us from Durban, we've got Professor Salim Abdool Karim, who is the chair of the Presidential Advisory Committee on COVID-19. Prof, it is so good to have you on the show. Welcome.
Good morning. Good morning to all the viewers.
So I know that your nickname is Slim, not because of your weight, but because of your brains. That's what I've been reading about you. Is this a fact?
Yes, it's a nickname I acquired when I was still in high school. Okay. When my Afrikaans teacher, "Jy dink jy is slim."
Well, we think you slim too, so that's why we're going to be quizzing you with loads of questions here, because I think you tend to be the man we turn to when we need a lot more understanding as to what's going on. So let's start where we're at, and we're looking at the current numbers. They are increasing, and they're increasing substantially. Was that expected, as the testing capacity obviously is increasing, or does it simply indicate that the infection is growing in South Africa?
So I think it reflects two things that we're grappling with. The first is that the epidemic is expected to grow, so we shouldn't get concerned about that. But much of the increase we are currently seeing is a result of increased testing. So we have been roughly doubling our testing every week or so. So if you increase your testing in such a drastic way that it's going up, you have to expect that the cases will also go up. It's not because they are new, lots of new patients, rather that it's just simply a function of that you are finding them. And that was the whole goal. The whole purpose of us establishing the community outreach program was to go and find the cases, so that we can deal with them rather than them remaining hidden in our communities. If we look at the overall proportion of tests that are positive, that has remained fairly stable. So at this point, we are reasonably confident that we don't have any dramatic increase in COVID patients. However, it's going to change. The release of the easing of the lockdown, the way in which people are going to interact with each other, we can expect that it will go up. Yeah. And we'll principally see that in the form of little outbreaks that will occur in hospitals, in schools, in prisons. We shouldn't get concerned. That is how the virus spreads. We have to mitigate it. We have to deal with it. And it's just part and parcel of how we're going to have to live with this virus and its threat.
Yeah. I mean, when we look at numbers that went through Italy, France, Spain, America at the moment, I mean, New York alone, we've got the UK, these numbers are massive. Our numbers in comparison are still a little bit low. Why? What's going on?
So I think at this stage, because of the very early actions taken, that was with the national state of disaster, closing the borders, closing the schools, and taking quite drastic action in terms of reducing people's interactions. What happened was that those people who were initially having the virus, they didn't spread it to many others. So what we are seeing is the net impact of slowing the spread to other people. But we have always said that we cannot beat this virus. That was never the intention. We're not expecting that there will be no epidemic. We made that very clear right from the word go. What we are trying to do is to flatten the curve. So in other words, we're trying to get our cases in a way that we can cope with it at our hospitals, our medical institutions. So if we can cope in our medical care facilities, then we will maintain a low death rate. And that's been our goal. Because there is no natural immunity to this virus. There is no vaccine. So we are always going to carry that risk. But as long as we can flatten the curve and spread out our cases, we'll be in a much better situation than Italy or New York.
Yeah. We certainly don't want to land up in that situation at all. When we talk, however, of these increases and flattening the curve, I mean, 437 new cases, and we've now moved to level 4. That number, those were the reported cases that we got yesterday. With this level 4 coming in now, are you prepared to be seeing a lot more infections coming through? Is that what we have to now understand is going to happen?
Yeah, and as the number of existing cases is high, you would expect a larger number of new cases. So that is to be expected. So when people tell me, oh, there's 300 cases, I said, that's nothing to be concerned about. When you talk about just one city in Italy, was having more than 10, 20,000 cases in a day. So it's not a concern at this point because it's well within the sort of levels of expectation that we have. That, however, means that if we stop our social distancing, our hand washing, our hand sanitizing, and so on, we run the risk that number will go out of control. So as long as we continue our precautions, we can expect that number will grow at a slow rate.
Yeah. I mean, Prof, you're obviously not immune to seeing what is happening on the streets of South Africa. We're seeing shopping centres that are packed. There is no such thing as social distancing happening there. We saw queues at SASA yesterday at different pay points where the elderly were gathered together. Again, no social distancing, some not wearing masks, no sign of sanitation. These are the things that we're advocating must be done. However, in large groupings, it is something that's not happening. This must worry you when you see things like this.
I think we have to do our best, and I would say that the highest priority is for us to do what we can to protect those who are over 70 years old. Even I would say between 60 and 70 also carries a risk, but I'm particularly concerned about those who are over 70, where we really need to do as much as we can to mitigate their risk. So when I see old people standing in a queue amidst a lot of other people handling things and so on, that is deeply concerning. And we just have to, keep emphasizing that these are high-risk individuals. We need to do our best to protect them. I think there's at some stage we're going to have to establish the new norms. That there should never be any queue that does not have spaces in between. And the way in which we create those spaces, either by putting, crates or little obstacles so that people don't get too close to each other, is going to have to be the new norm. And we're not completely ready for that. I wish we were, but I think we'll hopefully get there over the next few days.
We talk about not being ready, and that has been a concern of a lot of South Africans, that were we honestly ready to leave level 5 and go to level 4? Because when we first heard you speaking and you gave us those projections of yours, I think you spoke to, and I am at the same time asking questions from viewers in what I ask you as well. This is one coming from one of our viewers saying, why did we ease the lockdown? Though the curve depicted fell way below your advice to easing at the average of 44 infections per day. The infections were and still are above your recommendations. So what happened there?
So when I shared my recommendations about criteria by which we can assess where the epidemic is, we were talking at a time when the number of tests were fairly stable. And also that we were focusing largely on tests in our hospitals and clinics. Everything changed on the 7th of April because we put in place 28,000 community healthcare workers to go door to door and to test large numbers of people. So the number of cases had to go up, and the source of tests has changed completely. So you can't compare the old with the new because they're not apples and apples. So we have to create a new set of criteria. So the criteria that is more appropriate as the number of tests increases and as the source of the testing changes. And that is the percentage of positive tests. Now that's a better marker. And right now, over the last 5 weeks or so, that percentage has been fairly stable within a narrow range. It goes up and down, you have to expect that. But overall, when you average it out, it is a pretty stable estimate, running roughly between 2.7 and about 3.7%. So based on that, we can be reasonably confident that we don't have a runaway exponential growth epidemic. We have a slowly growing epidemic. And that's what we expected. And our goal was always to flatten the curve. That's what flattening the curve is.
And we attribute this to an early lockdown. Is that really what it was? Is that we went into lockdown before this started getting out of control?
Yeah. And you heard already that the Minister of Health articulated the fundamental issue that even if we maintained level 5, the level of benefit we would have continued to gain would have diminished. So there is no reason for us not to switch at this stage from level 5 to level 4. There, in fact, are parts of the country that will probably be even ready to go to a lower level sooner rather than later. And that's being always assessed and carefully monitored before those decisions are made.
Are you able to explain to us the levels? Because that is something, again, that South Africans are wanting to understand. When can we leave a different level? Like we left level 5, for what reason? We're going to leave level 4, for what reason? Can you tell us where do we need to be as a country to go down to level 3 and then eventually down to level 1?
So I'm probably not best placed to explain that, but I can tell you why we moved from level 5 to level 4. And the basis of level 5 was for us to try and achieve a low level of community transmission. That was our goal, and we set out to do that. That was achieved. And there was not much more to be gained or achieved on that score. And so ending the level 5 at the end of last month made sense for that reason. Now, the remaining levels and how they are determined is actually done at another level that I'm not familiar with all of the factors that are considered in that process.
So, Prof, let's talk to the epicenter now, because we've seen that Gauteng in the beginning was the epicenter. There's been a shift now to the Western Cape, and their numbers appear to have increased exponentially. What's happening there?
So I haven't done a very detailed analysis, and so somebody from the provincial level would be better able to comment. I think one of the key things that we see in the Western Cape is they do a much more testing. So a much higher proportion of the population is being tested than we see in other parts of our country. So part of the increased number of patients or cases is a function of their testing. But that's not the entire story, I think. And I've yet to have a more detailed look at the data with our colleagues from the Western Cape to understand it. And so I'm not in a position to comment much more than that.
So hopefully you're in a position to comment on this, and it's the raging tobacco war that's out there, and the alcohol war. So let's perhaps get your professional opinion on this. There are many people asking, smoking cigarettes or any other tobacco-related product is something that you, as a person, can decide for yourselves. It's never been healthy to do that, and it's been done before. Why ban it now? I'm asking you this purely because obviously this is it's a big talking point, and as a professor looking into medical explanations and coronavirus, does it make the situation worse? Do you think that the government is right by banning the sale of tobacco-related products?
So I'm not in a position to comment on the tobacco or any of those issues. I can say that as a whole, we've tried to advise the government about what are factors that mitigate the impact of severity and of risk from the coronavirus. And there are many things that do that. For example, with alcohol, we've seen the way in which it's had quite a traumatic effect on our emergency rooms at hospitals, which was what was the intention, that we wanted to clear the emergency rooms so that when the surge of cases came into the emergency rooms at our hospitals, that they were going to be in a position to deal with it. And so our advice has been largely in terms of what would help our country move forward in terms of being better prepared for the impact of this epidemic, but also what can we do that might minimize the risk of transmission.
I want to also move on to, there's so much I need to ask you, and I know our time is limited, but I want to speak to you again about an issue that comes up, and that is, of course, schooling. Plans to get learners back to school, other institutions and government organizations also getting ready to open up now. But with particular attention to schools, what is your view here? Is it, in your opinion, fine to allow school kids to go back into a learning environment?
So one has to take the context into account, but I can summarize it by saying yes. I see no reason why schools shouldn't open. And let me explain it like this. We will not have a vaccine in all likelihood until sometime late next year. And that's being optimistic, because not only do we need to develop the vaccines, test them, license them, produce them, and then give them out to people. So we will not end up with a situation where we will have a level of immunity in our community that will be protective until we have a vaccine and we've vaccinated about 60 to 70% of our population, depending on how many people got natural infection. So if we are working on the basis that we will have to live with this viral threat for the next year, possibly year and a half, we have to either make the decision that we're not going to go to school for the next year to year and a half, or we're going to go to school and we're going to take every precaution that we can. But I'm essentially saying that we have to live with a new normal. We're going to have to learn to live with this virus. And we're going to have to learn to live with the threat it poses to us. Because it's not going away. Yeah. It's going to be with us. We will see, a wave coming through, and we'll see a large number of cases in the next few months. And then that will wane. But we will then be at risk of another wave and another wave. So this is not something that's going away. So what options do we have? One option is, we say, let's close the schools and maybe we'll open in 2022. Or we can say, let's let's go with the best option we have at the moment, which is to mitigate that risk. Do everything we can to reduce that risk. If we go on that basis, we have to recognize that within schools, we will see outbreaks. I can't see how that will not occur. It's in the nature of the way this virus spreads. We will see outbreaks in prisons. We will see outbreaks in hospitals. We will see small outbreaks. I talked about it. We will see these flames. What we must do is we must be there to identify the flames and to douse them. Don't get concerned that they are flames. Those little outbreaks will occur. For me, the key thing with schools is that when the children go home, they must reduce their interaction with their grandparents. Because I worry about the elderly and the exposure to the elderly. And if we can do that, I see no reason why we shouldn't do as much as we can to try and get back as many of the things that we do. Remember, going to school will be almost as much a risk as many other things, like going to the local clinic or going to the shopping mall. All of those things will pose a risk because the virus will be with us in a ubiquitous way.
Prof, projections. You spoke about projections a bit early on, and I think let's look to that. What are your projections? How many infections? And I know I'm asking you almost an impossible question, but I imagine you have done graphs, you've looked at that with opening up South Africa, with speaking to the fact that people are going to get infected with this virus. How many South Africans do you believe will get this? Obviously not an accurate number, but there or thereabouts. And are we ready as a country to deal with this when it comes to protective gear, when it comes to ventilators, when it comes to our hospitals? Are we ready for this? And let's talk projections now.
So I don't do mathematical modeling, so I don't really do projections. So I'm not the best person to ask about that. But I can tell you that just doing a sort of back of the envelope calculation, I think we will probably see a peak of the epidemic in our country somewhere around July, August, maybe even early September, somewhere there. So in the next 2 months or so, that's what we should expect will occur.
Yeah.
It's hard to say how many people are going to get infected. The modelers, have done some predictions and so on. I think we have an opportunity to minimize that number because if we can get most of our workplaces and most of the areas where people gather, if we can institute controls that include social distancing, mask wearing, hand washing, I think we'll be able to control the total number. And so we may not see as bad an epidemic if we choose to do so. In other words, it's based on what behaviors we choose to follow. If we as a nation choose to ignore the rules, we have to acknowledge and accept we will see quite a severe epidemic. If we as a nation decide that we will find a way to live with this virus, we'll accept that we have to take these precautions, I think we won't see as bad an epidemic. But it's in our hands.
Yeah. In our hands to protect ourselves and to adhere to the advice that has been given and move forward from this. You spoke to the fact that there isn't a vaccine. I mean, nowhere in the world has it been proven that there's a vaccine. In fact, there was the gathering of the WHO yesterday with different European members also looking at getting a lot more money to go into this. However, we have got this talk of what's happening in Madagascar and the talk that some African countries are actually buying into it, the fact that they may have actually found something that may help. Can you talk to us about this? Do you have any idea or insight into what Madagascar are proposing to fight coronavirus?
So I haven't any first-hand knowledge about what exactly is contained in the tonic that is being promoted by the president and others in Madagascar. I think it's quite important that we have the opportunity to assess the evidence and determine whether there is enough proof that this is something that works or not. I would be very hesitant to encourage anyone to take anything without proof. We've already seen how chloroquine was promoted very early in this epidemic, and it turns out actually it has quite severe side effects and very little benefit, if any. So one of the big side effects we're seeing with high doses of chloroquine is sudden death. So you can do harm because you don't know what the evidence is for any particular treatment. Right now, there is no evidence to suggest that this Madagascan tonic does anything, good or bad. So I would say that what's important is that the evidence is submitted to the appropriate authorities like the World Health Organization or to the European regulators, and let somebody assess it, or even prominent African scientists, have them have a look at the data, as has been proposed by the African Academy of Sciences, and let's get a judgment based on that.
Some questions that people are asking now is, if you do get coronavirus, obviously the advice that you have been given is to self-quarantine, look after yourself and, just keep yourself away because you are highly infectious to those around you. Is there anything you're recommending that people can take? This is obviously for people that are not in need of going to hospital and having, very hectic treatment with regard to coronavirus. But people that do have it, obviously antibiotics are not going to work. What can you do to help yourself in this position?
So I think the main thing to do is to treat the symptoms. And in fact, when you go to hospital, that's pretty much what they do, is they treat the symptoms and they give you what is called supportive treatment. And the main support that we go to hospital for is that patients with this disease have some difficulty in getting enough oxygen from the air in their lungs into their blood. So when that happens, you need some support that's of a medical nature. So if you have shortness of breath and you're having difficulty breathing, then a hospital visit is required. But until then, if you are experiencing the other symptoms of an acute respiratory illness, things like, fever, cough, sore throat, you can just manage those with symptomatic treatment. Take some cough meds, take some antipyretics for the fever. So I think if you take that kind of approach, that's probably all that's required. But it's always in the context that if somebody has a positive test for COVID, that they must isolate themselves, because what's important is that they don't want to pass it on to somebody else who is at high risk, particularly older people or people with several diseases that put them at higher risk of COVID.
Yeah. We were talking a lot about reinfection, and there was a school of thought, and this, when I emphasize was a school of thought, that if you get coronavirus, chances are you'll move on and you won't get it again. Is this still the school of thought? I mean, is that where we're at, or getting reinfected, is that something that poses another risk to South Africans and the world?
So that's a very good question, and it's certainly a question that all of us would like an answer to. So let me share with you the evidence that's currently available and sort of do the best that I can to share with you what we know at the moment. So what we do know, because remember, we've only known about this virus for about 4 to 5 months. Yeah. So what we do know is that when a person gets this coronavirus infection, the vast majority will develop antibodies. And we know this from other viruses like measles and so on. And when you develop antibodies, generally it protects you. So you get measles once, you don't get it again. Or if you get the measles vaccine, you don't get measles. So it looks like in the coronavirus that when you've been infected, you develop antibodies, and there are a small proportion that don't. And it may be that they do, but we just can't detect them. But in a small proportion, we can't find antibodies. But in the vast majority, they develop antibodies. We don't yet know if those antibodies protect you from getting infected again. And we don't know for how long. If it does protect you, we don't know for how long. Because, as I said, we've only known about this virus for about 4 to 5 months. But what looks like the early evidence is becoming available suggests that if you have COVID, the disease, once, you don't get the disease again. So in other words, even if you were able to get infected again, you don't get the clinical illness a second time. But that's very early evidence, and we have to wait for time to pass to see now, 6 months later, are people who had disease, are they still not getting another disease of COVID again? So we can't answer that question definitively, but it's certainly at this point is suggestive that the antibodies that people generate might have some benefit, largely in preventing clinical illness.
Fascinating. So we're going to have to wait on that. But another issue, something that we as South Africans have been very, very worried about, and that, of course, is the HIV patient, the HIV AIDS, those who've got TB. Have we got information? Because, when we last spoke, there was still very little information as to how a body that is infected with HIV, AIDS, TB handles getting coronavirus. Where are we at with this? Do we have many cases at this point?
So we don't really have enough evidence coming from other countries because there have been very small numbers of patients that have HIV and also have had COVID. When we talk to our colleagues from China, in their entire series, several thousand patients, they had one patient, with HIV on ART, and who had a pretty uneventful course. There are more data coming out of New York, and there's some data coming from Spain, but those are very small and they're really descriptive studies. They're not intended to really study the impact of COVID on HIV. So I think at this stage, we don't really know whether HIV patients are going to get a more severe form of COVID or not. But we are planning on the basis that we expect the worst. And the way in which we want to go forward is that if it turns out that this group gets a severe form of COVID, that we are ready for it.
Yeah. And finally, as I wrap this interview up, there's still so many questions I can ask you, but I've had you for close on 45 minutes. So this is a really wonderful interview, and thank you again for your generous time. Exercise, doesn't that help? Doesn't it help to get out and whether we talk for mental wellness and just helping people better? We've been allowed 3 hours a day that a lot of people are saying is just, it's not enough. Professor, when we look around the world, that is something that many people are doing to get out and try and help themselves better. And it does make a big difference. Don't you think that we as South Africans deserve a little bit more when it comes to getting out and having some exercise?
Totally. Exercise is a key part of just general wellness, and not just, physical wellness, which is very important in this epidemic, but it's really good in terms of reducing your chances of heart disease, pulmonary disease. There is so many benefits from exercise. I would strongly encourage people to do as much exercise as you can, whether you want to do it indoors or whether you want to run on the streets or on the promenades. It doesn't matter to me. Rather, that you engage in that process. And the benefits will accrue not only from physical health, but also from mental health and from social health. So we will see quite a wide range of benefits. I hope we will soon see, many more opportunities in terms of, when the beachfront promenades and when opportunities become available for more exercise. I think we would hope to see that, especially as the levels down.
Thank you. Prof, thanks so much for your time. Professor Salim Abdool Karim, he is the chair of the Presidential Advisory Committee on COVID-19, talking to us about almost everything to do with COVID-19. What a pleasure to have him, and I hope that that's helped you a lot.